Hello everyone, today we will talk about liver diseases. But before to discuss about liver diseases, we have to refresh our knowledges related with the different functions of liver. The liver performs multifold functions, and first of all, synthetic function. Most serum proteins, with the major exception of the immunoglobulins, are synthesized in the liver. Albumin is the principal source of plasma oncotic pressure, and its decrease in chronic liver disease contributes to the development of edema and ascites. Clotting factors. You know well that blood coagulation depends on the continuous production of clotting factors, most of which, including prothrombin and fibrinogen, are synthesized by hepatocytes. Acute phase protein, complement, and other acute phase reactants are also secreted by the liver, as are numerous specific binding proteins, for example, the binding proteins for iron, copper, and vitamin A. The second important function of liver is related with excretory function. The principal excretory product of the liver is bile, and bile represents mixture of conjugated bilirubin, bile acids, phospholipids, cholesterol, and electrolytes. Bile not only provides a repository for the products of heme catabolism, but it also vital for fat absorption in the small intestine. Bile also contains immunoglobulins A, which is involved in enterohepatic circulation. Catabolic function. I hope you remember well that endogenous substances, including hormones and serum proteins, are catabolized by the liver to maintain a balance between their production and their elimination. Thus, in chronic liver disease, impaired catabolism of estrogens contributes to feminization in men, and especially it's related with hyperestrogenemia, or increased level of estrogens. Metabolic function. The liver is the central organ of glucose homeostasis and responds rapidly to fluctuations in the concentration of blood glucose. In the fat state, excess blood glucose is shunted to the liver to be stored as glycogen, and in the fasting state, the liver maintains blood glucose levels by glucogenolysis and gluconeogenesis. Catabolic function is related again with detoxification of foreign compounds or xenobiotics, such as drug, industrial chemicals, environmental contaminants, and products of bacterial metabolism in the intestine. And other very important function of liver is related with deposition, first of all, for glycogen, triglycerides, iron, copper, and vitamin A. Now we will discuss a little bit about most important clinical manifestations of different liver diseases. And first of all, is related with jaundice. Normal serum bilirubin concentration ranges from 0.3 to 1.3 milligram per deciliter, about 80% of which is unconjugated. Hyperbilirubinemia refers to an increased concentration of bilirubin in the blood, more than 1 milligram per deciliter. Jaundice, or other synonym is icterus, describes yellow skin and sclera whose color becomes apparent when the circulating bilirubin concentration exceeds 2 to 2.5 milligram per deciliter. Bilirubin pigment has high affinity for elastic tissue, and hence jaundice is particularly seen in tissues rich in elastin content. A rise of serum bilirubin between the normal and 2 mg per deciliter is generally not accompanied by visible jaundice and is called like latent jaundice. So here in this picture you can see manifestation of jaundice in the skin, very typical yellowish color of skin, and in sclera. Other important manifestation of especially chronic liver diseases related with abnormal metabolism of bile includes itching dermatosis, and the most typical from this group is prurigo nodularis. You can see in the skin a lot of noduli, violet and reddish in color, and like a rule they are scratched by the patient. First of all, it's related with bile acids, first of all, in the blood in case of disruption of bile metabolism. I don't have a time for focus on normal bilirubin metabolism. I hope you remember up to 80 to 85% of bilirubin is derived from old erythrocytes, which are removed from the circulation by mononuclear phagocytes of the spleen, bone marrow, and liver. The remaining 15 to 20% of the bilirubin comes from non-hemoglobin hem-containing pigments such as myoglobin, catalase, or cytochromes, and partly from ineffective erythropoiesis. We distinguish different phases in metabolism of bilirubin: blood phase, hepatic phase, and enterohepatic circulation in intestinal phase. Hepatic phase include or involves different steps like uptake, binding, conjugation, and excretion of bile. Based on pathophysiology, based on these steps of metabolism, jaundice may result from one or more of the following mechanisms: increased bilirubin production, decreased hepatic uptake, decreased hepatic conjugation, and decreased excretion of bilirubin in the bile. A simple age-old classification of jaundice include three forms of jaundice: prehepatic or hemolytic, hepatic or parenchymatous, and posthepatic cholestatic or mechanical or obstructive jaundice. As you can see in this slide, two first types of jaundice are associated mainly with increased amount of unconjugated bilirubin, and posthepatic cholestatic jaundice mainly with increased amount of conjugated bilirubin. Here you can see classification of jaundice according to predominantly unconjugated or conjugated hyperbilirubinemia. Unconjugated hyperbilirubinemia include increased bilirubin production. Typical example, hemolysis. And this hemolysis could be intra and extravascular or ineffective erythropoiesis. Unconjugated hyperbilirubinemia occurs in case of decreased hepatic uptake, for example, due to influence of drugs, prolonged starvation, and sepsis. And the last causative factor related with unconjugated hyperbilirubinemia is decreased bilirubin conjugation. In case of some hereditary disorders like Gilbert syndrome, Crigler-Najjar syndrome, in case of some acquired defect, for example, drugs associated, in case of inflammatory liver diseases like hepatitis, or in case of cirrhosis and neonatal jaundice. The hyperbilirubinemia of uncomplicated hemolytic disease principally involves unconjugated bilirubin, whereas in parenchymal liver diseases, both conjugated and unconjugated bilirubin participate. You have to memorize this. So, predominantly conjugated hyperbilirubinemia occurs in intrahepatic and extrahepatic cholestasis. Intrahepatic cholestasis is related with impaired hepatic excretion, for example, in some hereditary disorders or pure cholestasis, and some acquired disorders or hepatocellular cholestasis. And extrahepatic cholestasis related with extrahepatic biliary obstruction, and we can see this type of jaundice in mechanical obstruction of bile, extrahepatic bile ducts, related with formation of gallstones, inflammatory strictures, carcinoma head of pancreas, etc. Other very important clinical sign related with liver diseases is hepatic failure. Is the clinical syndrome that occurs when the mass of liver cells or their function is inadequate to sustain the vital activities of the liver. And here we distinguish two types of hepatic failure: acute or fulminant and chronic. Acute occurs most frequently in acute viral hepatitis and in other diseases like hepatotoxic drug reaction, mushroom poisoning, etc. Chronic hepatic failure most often occurs due to cirrhosis, and other causes include chronic active hepatitis, chronic cholestasis, and Wilson's disease. Here in this slide you can see the scheme of more important clinical manifestations related with hepatic failure, and now we will focus on all of them. So the first manifestation, clinical manifestation of hepatic failure is jaundice. Usually reflects the severity of liver cell. In acute failure, nearly parallels the extent of liver cell damage, and in chronic failure, jaundice appears late and is usually of mild degree. Other manifestation we name like hepatic encephalopathy or hepatic coma. It represents neurological syndrome, and this syndrome may complicate liver diseases of both acute and chronic types. The features include different manifestation, neurological manifestation, for example, personality changes, intellectual deterioration, low slurred speech, flapping tremors, and finally coma and death. The genesis of CNS manifestation is by toxic products not metabolized by the diseased liver, and the toxic products may be ammonia and other nitrogenous substances from intestinal bacteria which reach the systemic circulation without detoxification and thus damage the brain. Advanced cases of hepatic coma have poor prognosis but may respond favorably to hepatic transplantation. Next manifestation we name like hyperkinetic circulation. So all forms of hepatic failure are associated with this manifestation, and hyperkinetic circulation is characterized by peripheral vasodilatation, increased splanchnic blood flow, and increased cardiac output. There is increased splenic flow but reduce renal blood flow, resulting in impaired renal cortical perfusion. And these changes result in tachycardia, low blood pressure, and reduced renal function. Other manifestation we name like hepatorenal syndrome. Term is applied to patients of both acute and chronic hepatic failure who develop renal failure as well in the absence of clinical, laboratory, or morphologic evidence of other causes of renal dysfunction. Diagnosis is made only after excluding other causes producing concomitant damage to both the organs, circulatory failure leading to acute tubular necrosis, and other forms of reversible tubular damage. The pathogenesis is poorly understood. It seems to be initiated by effective reduction of the renal blood flow as a consequence of systemic vasodilatation and pooling of blood in portal circulation. The renal failure is reversible with improvement in hepatic function. The next manifestation is hepatopulmonary syndrome. It occurs in chronic hepatic failure and consists of pulmonary vasodilatation with intrapulmonary arteriovenous shunting. Results in ventilation perfusion inequality that may lead to impaired pulmonary function, clubbing of fingers, and sometimes cyanosis. Other manifestation is related with coagulation defects. Impaired synthesis of a number of coagulation factors result in coagulation disorders. First of all, we talk about disseminated intravascular coagulation, thrombocytopenia, and presence of fibrin degradation products in the blood. The next manifestation we name like ascites and edema, decreased synthesis of albumin by the liver resulting in hypoproteinemia and consequent fall in plasma oncotic pressure, increased hydrostatic pressure due to portal hypertension, and secondary hyperaldosteronism. Endocrine changes. First of all, they are associated with chronic hepatic failure. In male, the changes are towards feminization. We discussed about in the beginning of the lecture. First of all, we will see gynecomastia and hypogonadism. In female, the changes are less toward masculinization, but atrophy of gonads and breasts occurs. Skin changes. They are related, first of all, with vascular changes or vascular manifestations of hyperestrogenism. And they include spider angiomas and palmar erythema. And other skin manifestations, again, we discussed a little bit in the beginning of the lecture. They are related with itching dermatosis like prurigo nodularis. And last clinical manifestation of liver failure, we name like fetor hepaticus. It represents a sweetish, pungent smell of the breath. It appears to be of intestinal origin, possibly due to failure to detoxify sulfur-containing substances absorbed from the gut. So here you can see skin manifestation with erythema and formation of spider angiomas in the skin, and this symptom we name like gynecomastia. Other very important clinical manifestation, and we can say complication of liver diseases is portal hypertension. Sustained increase in portal venous pressure and results from obstruction to blood flow somewhere in the portal circuit represents portal hypertension. Arising at the junction of the superior mesenteric vein with the splenic vein, the portal vein carries the major venous drainage from the GIT, the pancreas, the spleen into the liver. Normal pressure in the portal vein is 7 to 14 centimeters of water. A pressure greater than 30 centimeters of water defines portal hypertension. The major complications of portal hypertension include bleeding from gastroesophageal varices, ascites, and splenomegaly. When we talk about causes, possible causes of portal hypertension, they could be absolutely different, and we distinguish three types of portal hypertension related with different causative factors. For example, it could be prehepatic portal hypertension is often caused by portal vein thrombosis. Portal vein thrombosis occurs most commonly in the setting of cirrhosis. Other causes of portal vein thrombosis include tumors, infections, hypercoagulation, pancreatitis, surgical trauma, for example, primary hepatocellular carcinoma with occlusive invasion of the portal vein obstruction by a septic thrombus in patients with splenomegaly from a variety of causes. Intrahepatic portal hypertension is usually caused by cirrhosis. Regenerative nodules in the cirrhotic liver impinge on the hepatic veins, thereby obstructing blood flow distal to the lobules. The small portal veins and venules are trapped, narrowed, and often obliterated by scarring of the portal tract. Moreover, blood flow through the hepatic artery is increased and small arteriovenous communications become functional. In this way, portal hypertension due to obstruction of blood flow distal to the sinusoid is augmented by increased arterial blood flow. In addition, increased splenic arterial blood flow, whose cause is unclear, is an important factor in the maintenance of portal hypertension. Intrahepatic vasoconstriction in cirrhosis may exacerbate portal hypertension. Central venous sclerosis and sinusoidal fibrosis also contribute to the development of portal hypertension in alcoholic liver disease. In fact, portal hypertension can result from alcoholic central sclerosis alone, even in case that don't progress to cirrhosis. And other type of portal hypertension is related with post-hepatic causes. Post-hepatic portal hypertension refers to obstruction to blood flow beyond the liver lobules. Occurs in Budd-Chiari syndrome and hepatic vena occlusive disease. So, Budd-Chiari syndrome is a congestive disease of the liver caused by occlusion of the hepatic veins and their tributaries. Thrombosis of the hepatic veins in association with such diverse conditions are as polycythemia vera and other myeloproliferative disorders, hypercoagulative states associated with, for example, malignant tumors, or the use of oral contraceptive, pregnancy, bacterial infections, metastatic and primary tumors in the liver, and surgical trauma. Thrombosis is most common in the large hepatic veins close to their exit from the liver and in the intrahepatic portion of the inferior vena cava. Hepatic vena occlusive disease is a variant of the Budd-Chiari syndrome and is caused by occlusion of the central venule and small branches of the hepatic veins. Most commonly, this disorder is traced to the ingestion of toxic alkaloids in patients treated with some antineoplastic chemotherapeutic agents, and after hepatic irradiation, bone marrow, for example, transplantation. When we talk about portal hypertension, there are some very important systemic complications, and the first complication is esophageal varices. This complication represents the most important complication of portal hypertension. Arise from the opening of portal systemic collaterals as an adaptation to decompress the portal venous system. One of the most common causes of death in patients with portal hypertension, because it leads to bleeding from esophageal varices. The collaterals of most clinical significance are located in the submucosal layer of the lower esophagus and upper stomach, and are the result of communications between the portal vein and the gastric coronary vein. The back pressure in the portal vein is also transmitted to the inferior hemorrhoidal veins, which become dilated and tortuous, and we name this condition like anorectal varices, and collateral veins radiating about the umbilicus produce other pattern known as caput medusa. So here you can see the patient with ascites, and in the skin you see well visible veins, and here you see classical manifestation of caput medusa. And in this slide, in these two pictures, you can see this is endoscopy, endoscopic picture, and you can see different severity of esophageal varices. In case of small varices, like here, and large varices, when the veins are dilated and the surface is wavy. Other systemic complication related with portal hypertension is splenomegaly. In case of portal hypertension, the spleen enlarges progressively and gives rise to the syndrome of hypersplenism, a decrease in the life span of all of the formed elements of the blood, and it leads to reduction in their circulating numbers. And finally, it leads to pancytopenia. Is attributed to an increased rate of removal of erythrocytes, leukocytes, and platelets because of the prolonged transit time through the hyperplastic spleen. And grossly, the spleen is enlarged and firm. Its cut surface is uniformly deep red with an inapparent white pulp. Microscopically, sinusoids are dilated, their walls are thickened by fibrous tissue and lined by hyperplastic endothelial cells and macrophages. Other systemic complication of portal hypertension is ascites. Refers to the accumulation of fluid in the peritoneal cavity. The retention of sodium and water in cirrhosis is clearly important in the pathogenesis of ascites. And the mechanisms for altered sodium and water homeostasis in cirrhosis remain controversial, but three major hypotheses can be considered: hypovolemia, overflow, and vasodilation. And last systemic complication of portal hypertension is spontaneous bacterial peritonitis. Is an important complication in patients with both cirrhosis and ascites. Presumably, the ascitic fluid is seeded with bacteria from the blood or lymph, or by the passage of bacteria through the bowel wall, and the infection is extremely dangerous and carries a very high mortality even when patient is treated with antibiotics. Before we will start to talk about morphological manifestation of liver diseases, we have to refresh normal histology of liver. So you remember well that hepatic parenchyma is composed of numerous hexagonal or pyramidal classical lobules. So each classical lobule has a central tributary from the hepatic vein, and in the periphery are 4 to 5 portal tracts or triads. So here we see central vein, in the periphery portal tracts, and they containing branches of bile duct, portal vein, and hepatic artery. Cords of hepatocytes and blood containing sinusoid radiate from the center to the periphery, if you remember, I hope so. When we talk about the direction of sinusoidal blood, so from the periphery in the center. The functional lobule or liver acinus, as described by Rappaport, has a portal triad in the center, and is surrounded at the periphery by portions of several classical lobules. However, in most descriptions on pathology of the liver, the term lobule is used in its classical form, first of all, polygonal form, and in this area we distinguish functional liver lobule or acinus like triangle, and this triangle is derived from the gradients of oxygen and nutrients in the sinusoidal blood and divided into 3 zones. Zone 1, or the periportal peripheral area, is close to the arterial and portal blood supply and hence bears the brunt of all forms of toxic injury. Zone 2 is the intermediate or mid-zonal area, and zone 3, or the central lobular area, surrounds the central vein and is most remote from the blood supply and thus suffers from the effects of hypoxic injury first of all. So the hepatocytes are polygonal cells with a round single nucleus and a prominent nucleolus. You remember well that liver cells have a high capacity to undergo mitosis and regeneration. So it's not uncommon to find under microscope liver cells containing more than one nucleus and having polyploidy. The blood-containing sinusoids between cords of hepatocytes are lined by discontinuous endothelial cells and scattered flat Kupffer cells belonging to the reticular endothelial system. Then in the liver we distinguish the space of Disse, is the space between hepatocytes and sinusoidal lining endothelial cells, and few scattered fat-storing eta cells lie within the space of Disse. Well, what else? The portal triad or tract, besides containing portal vein radicle, the hepatic arterial and bile duct, and normally can have few mononuclear cells and scanty connective tissue, considered to be an extension of Glisson's capsula. So the intrahepatic biliary system begins with the bile canaliculi interposed between the adjacent hepatocytes. The bile canaliculi are simply grooves between the contact surface of the liver cells and are covered by microvilli. So I hope we refreshed a little bit our knowledge about histology of liver. And in this picture you can see histological slide, and all 3 listed before zones are present. So here there are central vein. Around of central vein we see zone 3. Here this is portal tract, and we can see connective tissue of portal tract with the vein and arteries and bile ducts, and this periportal zone we name like zone 1, and between these zones we see intermediate zone number 2. So type of liver cell necrosis. Honestly, according to mechanisms of development in the liver, we can find typical necrosis like in other tissues, for example coagulative necrosis and colliquative necrosis. Coagulative necrosis is caused first of all by ischemia or toxic injury, and colliquative necrosis are related with active inflammation accompanied with bowel and hydropic degeneration of hepatocytes and, like result, osmotic lysis. According to the extent of involvement of hepatic lobule, we distinguish three types of necrosis: diffuse, zonal, and focal necrosis. Diffuse necrosis is extensive and diffuse necrosis of the liver involving all the cells in groups of lobules. Is most commonly caused by viral hepatitis or drug toxicity. And if this necrosis include whole lobule, we name this diffuse necrosis like submassive. If necrosis happens in several lobules, we name this diffuse necrosis like massive necrosis. The second group of necrosis is zonal necrosis. It represents necrosis of hepatocytes in three different zones of the hepatic lobule and includes different types. The first is centrolobular, is the commonest type, involve hepatocytes in a third zone, and centrolobular necrosis is characteristic feature of ischemic injury, such as in shock, for example, since zone 3 is farthest from the blood supply. Mid-zonal is uncommon, involves zone number 2, and is seen in yellow fever and in some viral hepatitis. Other subtype of zonal necrosis is periportal or peripheral necrosis. Is seen in zone 1, involving the parenchyma closest to the arterial and portal blood supply. Since zone 1 is most well perfused, it's most vulnerable to the effect of circulating hepatotoxins, for example in case of poisoning or eclampsia. Piecemeal zonal necrosis is defined as periportal destruction of hepatocytes at the limiting plate. Piecemeal means piece by piece. This subtype of zonal necrosis are located on the border of portal tract. And the last subtype of zonal necrosis is bridging necrosis. This type of necrosis is characterized by bands of necrosis linking different structures of hepatic lobules. For example, portal tract to central hepatic veins. So we name this bridging necrosis like portocentral necrosis. One central hepatic vein to another. So this is central necrosis, and portal tract to another tract like portal necrosis. So here in this slide you can see the examples. When the necrosis are located around, bridging necrosis located around of central vein, we name this necrosis like centrilobular. Then piecemeal necrosis, small foci and close to portal tract, so we name like piecemeal necrosis. And bridging necrosis, portocentral, portal, and central necrosis. And the last subtype of liver cell necrosis is focal necrosis, involves small groups of hepatocytes irregularly distributed in the hepatic lobule, most often caused by macrobiologic infections like viral hepatitis, tuberculosis, typhoid fever, etc., and may also occur in drug-induced hepatitis. So now we move on the liver diseases. and the first is group of hepatosis. As usually, we start with definition. Hepatosis represents degeneration and or necrosis of hepatocytes without inflammation. Honestly, I'm not totally agree when we talk about when we use this term without inflammation, because if you remember from first semester, when we talk about some types of dystrophic processes and necrosis, every time we see inflammatory reaction around. For that, we can see inflammation in case of hepatosis, but morphologically degenerative and or necrotic features predominate. We distinguish two types of hepatosis, acute and chronic. Acute, they lead to acute liver failure and include microvesicular steatosis and massive progressive liver necrosis. The old term of this disease is toxic liver dystrophy. Chronic hepatosis, they represent macrovesicular steatosis and don't have significant clinical implications. And they are typical for alcoholic and non-alcoholic fatty liver disease. Briefly about massive progressive liver necrosis. To represent progressive and massive dystrophy and necrosis of the liver, the most typical causes are related with toxic substances. They could be exogenous intoxications like toxic mushrooms or different chemicals, or endogenous intoxications of microbial or non-microbial origin. In case of acute viral hepatosis with massive necrosis, sepsis, thyrotoxicosis, toxemia of pregnancy. In this disease, we distinguish two morphological stages: stage of yellow dystrophy or degeneration and stage of red dystrophy or degeneration. The first stage occurs in the first week of the disease, and macroscopically liver is enlarged in size, yellow in color, and has flabby consistency. Microscopically, we will see prominent fatty degeneration of hepatocytes with central-lobular necrosis and formation of fat protein detritus. On the periphery, as you can see in this slide, the hepatocytes are not destroyed. We don't see necrotic changes, but we see fatty dystrophy of hepatocytes in the periphery, the right portal tract here. And you can see that in this zone, the hepatocytes are with fatty dystrophy. Second stage, we name like stage of red dystrophy or degeneration. It occurs in third week of the disease, and we see absolutely different morphological picture. Macroscopically, the liver is reduced in size and has red color. Microscopically, fat protein detritus undergoes resorption. Bearing of thin reticular stroma of the lobules happens, and we see well visible full-blooded sinusoids. And this congestion is related with this red color of liver in this stage of disease. Then reticular system and stroma collapse, and all the remaining parts of the lobes converge. Steatosis or fatty hepatosis. represent fatty degeneration of liver, and fatty degeneration is the most common degeneration of hepatocytes because it represents a typical response to a variety of hepatotoxins. We distinguish acute and chronic steatosis, congenital and acquired. Two morphological patterns in liver steatosis occur: macrovesicular and microvesicular. So here in this table you can see the most important differential criteria, morphological and clinical criteria between micro and macrovesicular steatosis. So they have absolutely different pathogenesis. Microvesicular steatosis is related with violation of beta oxidation of fat, and microvesicular fatty liver is commonly associated with severe and sometimes fatal liver disease, and for that acute liver failure occurs in this case. Not much is known regarding the pathogenesis of microvesicular steatosis, but first of all, we suppose that it's strictly related with violation of beta oxidation of fat, and like result, it occurs in many instances the primary defect of mitochondria. So, light microscopy shows small fat vacuoles dispersed throughout the cytoplasm of hepatocytes, and it's very important to understand that the fat is accumulated in mitochondria first of all, and the nucleus retains its central position. Again, it's not the presence of fat but the underlying metabolic defect that produces the liver dysfunction. In case of macrovesicular steatosis, in pathogenesis of this type of steatosis, metabolic disorders of lipoproteins play critical role. Light microscopy shows the cytoplasm of the liver cells to be occupied by fat, seen as a large clear area that distends the cell and displaces the nucleus to the periphery. In addition to its association with chronic ethanol ingestion, macrovesicular fat results from the experimental administration of or accidental exposure to such direct hepatotoxins are carbon tetrachloride and the poisonous some mushrooms. Moreover, corticosteroids and some antimetabolites such as methotrexate may cause macrovesicular steatosis. So there is no reason to believe that the presence of fat per se is injurious to the hepatocytes. Rather, its accumulation reflects the underlying liver cell damage. And functionally, this type of steatosis has almost no effect. And if we will look under microscope, we can see these two different pictures. So here, this is example of microvesicular steatosis when the hepatocytes are enlarged and contain a lot of small fatty vesicles, but the nucleus is located in the center of cell. Here in this slide we see that there are a lot of hepatocytes with large clear vacuole and with nucleus located in the periphery. If you remember the first semester when we discussed with you about parenchymatous fatty dystrophy, we discussed that this type of dystrophy begin from small vacuoles, and you can see in some hepatocytes just small vacuoles, and then these small vacuoles transform to medium-sized and finally to large vacuoles. But in case of these small vacuoles, you can see that they are not so multiple like in case of microvesicular steatosis, because here the pathogenesis is strictly related with mitochondria, but here the lipids are located just in cytoplasm of cell. Microvesicular steatosis is related with some diseases, first of all with Reyes syndrome, acute hepatosis of pregnancy, and in some cases of alcoholic liver disease. I want to focus your attention in Reyes syndrome, this rare acute disease of children, and is characterized by microvesicular steatosis, hepatic failure, and encephalopathy. Cerebral edema and fat accumulation are reported in the brain, and so we can see this clinical manifestation, neurological, related with encephalopathy. The symptoms usually begin after a febrile illness, commonly influenza or varicella infection, and are claimed to correlate with the administration of aspirin. Clearly, Reyes syndrome is more complex than simple aspirin toxicity, because the doses of aspirin consumed were far too small to produce liver injury. In any event, with the decline in the use of aspirin in children and possibly a reduced incidence of influenza, Reyes syndrome is now distantly uncommon. Macrovesicular steatosis is typical, first of all, for alcoholic liver disease, non-alcoholic fatty liver disease, and hepatitis C and some other diseases. We move on, and now we will talk about hepatitis. Hepatitis represents a group of liver diseases characterized by the predominance of inflammation resulting in liver injury in the form of degenerative and necrotic processes. As you can see, in both groups of diseases, in hepatosis and hepatitis, the same morphological features are present, and they include degenerative processes, necrotic processes, and inflammation. But the predominance is different. In hepatosis, degeneration and necrosis predominate. When we talk about hepatitis, we see predominance of inflammation, but we can see and we see degenerative and necrotic processes. Classification of hepatitis is based on the etiology, so we can we distinguish viral, hepatotropic viruses and non-hepatotropic viruses. We distinguish autoimmune hepatitis, it's not so rare, and you remember that very common we can see association of multiple autoimmune diseases in the same patient. Metabolic hepatitis, like example Wilson's disease or hemochromatosis, non-alcoholic hepatitis, and toxic hepatitis, first of all related with drugs and alcohol. And based on the duration, of disease. We distinguish acute up to 6 months and chronic hepatitis. I want to focus a little bit in clinical pathologic spectrum of viral hepatitis. So here you can see this spectrum. The first is carrier state, an asymptomatic individual without manifest disease, harboring infection with hepatotropic virus and capable of transmitting this infection is called like carrier state. Asymptomatic infection. These are cases who are detected incidentally to have infection with one of the hepatitis viruses as revealed by their raised serum transaminase or by detection of the presence of antibodies, but are otherwise asymptomatic. You have to understand that this form is more dangerous when we talk about cases of transformation of acute forms of hepatitis to chronic. Acute hepatitis. The most common consequence of all hepatotropic viruses is acute inflammatory involvement of the entire liver. In general, type A, B, C, D, and E run similar clinical curves and show identical pathologic findings. And clinically, acute hepatitis is categorized into 4 phases: incubation period, pre-icteric phase, icteric phase, and post-icteric phase. Chronic hepatitis is defined as continuing or relapsing hepatic disease for more than 6 months with symptoms along with biochemical, serologic and histopathologic evidence of inflammation and necrosis. Majority of cases of chronic hepatitis are the result of infection with hepatotropic viruses, hepatitis B, hepatitis C, and combined hepatitis B and hepatitis D infection. And fulminant hepatitis related or accompanied with submassive to massive necrosis is the most severe form of acute hepatitis in which there is rapidly progressive hepatocellular failure. So, 2 patterns are recognized: submassive necrosis having a less period course extending up to 3 months, and massive necrosis in which the liver failure is rapid and fulminant, occurring in 2 or 3 weeks. Very important to remember that hepatitis A and E do not have a carrier stage nor cause chronic hepatitis. Morphologic spectrum of viral hepatitis includes listed in these slides features. First of all, hepatocellular injury. It happens, first of all, it's seen in the zone 3 in central lobular zone, and include hydropic or ballooning degeneration, acidophilic degeneration with apoptosis and like result formation of Count-Sielman body, and different types of necrosis. Then it includes inflammatory infiltrate like a rule mononuclear, usually in the portal tract, Kupffer cell hyperplasia, not severe cholestasis, and all features related with regeneration, first of all hyperplasia and fibrosis. During the lecture, unfortunately, we don't have a lot of time for discuss about morphological features of all hepatitis. We will do it during practical classes, but I want to focus your attention in some morphological differences of some hepatitis. As you can see here, we talk about viral hepatitis B, C, and non-viral hepatitis, no-alcoholic steatohepatitis, and alcoholic hepatitis. Which types of dystrophies or degeneration are typical for all these hepatitis? In case of hepatitis B, first of all, hydropic. In hepatitis C, we will see not only hydropic, but we see macrovesicular fatty dystrophy. The same in non-alcoholic steatohepatitis. In alcoholic hepatitis, we see hydropic, macrovesicular, and area of microvesicular fatty dystrophy. Specific features of cells, cytological changes are typical in case of viral hepatitis only for hepatitis B. First of all, it's related with microbiology of this virus. This virus is DNA virus, so the presence of this virus in the hepatocytes leads to transformation of cells. So we will see enlargement of cells, we will see polymorphism of cells. They look like ground glass hepatocytes and they have sanded nuclei. Sanded, it means that chromatin in the nucleus is distributed by small pieces. No specific changes we see in case of hepatitis C, and for non-alcoholic and alcoholic hepatitis, very typical presence of Mallory's bodies. If you remember from first semester, this is pinkish or eosinophilic globules in the cytoplasm of cells, and they represent result of hydropic droplets parenchymatous protein dystrophy. Apoptosis is common for hepatitis B, and we discussed a little bit before, like result of apoptosis, Councilman bodies are formed. Inflammation. In case of viral hepatitis, portal tracts and adjacent areas of hepatic globules are infiltrated by lymphocytes. In case of non-alcoholic and alcoholic hepatitis, we see the presence of neutrophils. Yes, we will see mononuclear infiltration, but we will see neutrophils especially around of Mallory's body. And fibrosis for both B and C viral hepatitis and non-alcoholic steatohepatitis. All types of fibrosis are typical except the central vein fibrosis, and for alcoholic hepatitis in general all types of fibrosis are typical. So here in this slide you can see morphology of hepatocytes with ballooning degeneration. You can see that the cells are enlarged and really they look like balloon. Here we see ballooning degeneration of cells. We see some features related with fatty dystrophy, and we see result of apoptosis of hepatocytes, and formation of Count-Sielman body. So here there are Mallory's body or Mallory hairline, pinkish masses in the cytoplasm of injured cells, and very common we can see reactive inflammation by neutrophils around of Mallory body. So here we see severe fatty degeneration of hepatocytes with hydropic dystrophy of some of them, with inflammatory infiltration in the portal tracts and some congestion and hemorrhages in the portal tract. And here we see severe inflammatory infiltration and thick fibrotic septa in portal tract with proliferation of bile ducts. For make a diagnosis of chronic liver diseases, we have to prove the presence of fibrotic tissue. For example, in case of chronic hepatitis. But in the beginning of fibrosis, it's very difficult to understand amount of extracellular matrix. For example, when we talk about mild form of fibrosis, for that we use obligatory additional staining. And here you can see the example of MSB staining, and this ink helps to distinguish first of all connective tissue. So here you see that hepatocytes, they have red color, and extracellular matrix, fibrotic tissue, has bluish color. And when we do this additional staining, it's easy to understand the severity of fibrotic changes in this biopsy or in this specimen of liver. Outcomes of viral hepatitis, it depends of form. In acute it could be cure, chronicity, and acute liver failure in fulminant forms. And in chronic viral hepatitis, first of all, this is cirrhosis development and hepatocellular carcinoma. Hepatocellular carcinoma, first of all, is related with viral hepatitis B and C. But it's better to say, to put hepatitis C in the first place, first of all, C and B. Before we will talk about cirrhosis, I want to talk a little bit about fibrosis of liver. Fibrosis in general represents excessive accumulation of extracellular matrix molecules in tissue. Extracellular matrix in normal liver is less than 3% of the cross-sectional area and located in portal tracts, the wall of the sinusoids around the central veins, and synthesized by fibroblasts of portal tracts, fibroblasts around the central veins, and eta cells. When we talk about liver fibrosis, when we see extracellular matrix content of 6 times above normal, when we see formation of septas similar with formation of bridging necrosis according to link between different components of hepatic globules. So they could be porta-central, centrocentral, and porta-portal. And in case of fibrosis, extracellular matrix is synthesized by periductal myofibroblast, by eta cell transformed into myofibroblast, by septa myofibroblasts, and by myofibroblasts around the central veins. So here you can see periportal fibrosis. So fibrosis of the central vein, perisinusoidal fibrosis, formation of porta-central septa, porta-portal septa, and central septa. And finally, in consequence of fibrotic changes in the liver, we will see cirrhosis formation. Cirrhosis is a diffuse process characterized by fibrosis and the transformation of the normal structure of the liver in structurally abnormal nodes. For make a diagnosis of cirrhosis, we have to have some criteria. First of all, you have to understand that cirrhosis represents irreversible end stage of several diffuse diseases causing hepatocellular injury and is characterized by the following 4 features. First of all, it involves the entire whole liver. The normal lobular structures of hepatic parenchyma is disorganized. There is formation of nodules separated from one other by irregular bands of fibrosis, and it occurs following hepatocellular necrosis of varying etiology, so that there are alternate areas of necrosis and regenerative nodules. And finally, we can see this morphological picture. So in the liver you can see multiple noduli or lobuli, but we name these lobuli like false lobuli because they don't have central vein and they are not organized like normal liver lobe. And all these false lobuli, they are surrounded by fibrotic tissue. We classify cirrhosis according to pathogenesis in 3 types: post-necrotic, portal, and biliary. And according to the size of false nodules, we distinguish micronodular, less than 3 mm, the size of nodule, macronodular, more than 3 mm, and mixed. Like a rule, post-necrotic cirrhosis is macronodular, and portal cirrhosis, first of all, is micronodular. So here in this slide I show you just the example how we make the diagnosis of liver fibrosis or liver cirrhosis. Again, you see this commonly used additional staining, MSB staining, because it's very important to distinguish fibrotic tissue. So in the first biopsy you can see well-formed noduli surrounded by very thick area of fibrotic tissue. In this biopsy we don't see well-formed noduli, but we can see severe fatty dystrophy with some necrotic area of hepatocytes with some amount of fibrotic tissue. And here again we can say that in this biopsy the amount of extracellular matrix, the amount of connective tissue is increased. Cirrhosis, when we talk about pathogenesis, a little bit for shortness, irrespective of the etiology, cirrhosis involves a combination of a few processes. Damage of hepatocytes. First of all, we talk about hepatocellular necrosis. Regeneration of hepatocytes with formation of compensatory regenerative nodules. Fibrogenesis, or healing by fibrosis, and changes in vascular pattern of the hepatic parenchyma. So, damage of hepatocytes, we discuss. It includes, first of all, necrotic changes, different types and severity. Regeneration of hepatocytes. The surviving hepatocytes act as stimulants for growth and proliferation of more hepatocytes under influence of growth factors. This compensatory proliferation of hepatocytes is restricted within fibrous nodules, forming regenerative or false nodules. Fibrogenesis. Continued destruction of hepatocytes causes collapse of normal lobular hepatic parenchyma, followed by fibrosis around necrotic liver cells. Fibrosis in the liver lobules may be different. We discussed with you, like porta-central, porta-portal, or central. The mechanism of fibrosis is by increased synthesis of type 1 and 3 collagen in the space of DC. There is proliferation of fostering eta cells underlying the sinusoidal epithelium, which are transformed into myofibroblasts and fibrocytes. Besides collagen, two glycoproteins, fibronectin and laminin, are deposited in excessive amount in area of liver cell damage. And the last very important element of pathogenesis of cirrhosis is related with vascular reorganization. Due to damaged hepatic parenchyma and formation of fibrous nodules, the new vessels formed in the fibrous septa are connected to the vessels in the portal triad, branches of hepatic artery and portal vein, and then the blood is drained in the hepatic vein. This way, the blood bypasses the hepatic parenchyma. Moreover, due to fibrous proliferation in the space of DC, gaps in the hepatic sinusoids are closed, which result in development of capillaries in the sinusoid, and we name this process like capillarization of sinusoids. In this slide you can see the scheme of portal cirrhosis formation. So, due to formation of different in types of fibrotic septas, false lobule is finally formed. In case of post-necrotic or macronodular cirrhosis, we will see a little bit different mechanism of formation. So, area of necrosis, and after resorption of necrotic tissue, we will see shrinkage of portal tract, and one of the typical morphological sign of post-necrotic cirrhosis is the presence of more than 3 portal tracts in one field of view under microscope. Complication of cirrhosis I just list. we discussed in the beginning of the lecture about chronic liver failure, portal hypertension, and other complication of cirrhosis is hepatocellular carcinoma. Briefly about alcoholic liver disease. So, is a set of clinical syndromes and pathological changes in the liver due to alcohol, especially ethanol. The main forms of alcoholic liver disease are steatosis, hepatitis, and cirrhosis. Alcohol is a direct hepatotoxic agent, and alcoholic liver disease develops if alcohol abuse for 10 to 12 years is 40 to 80 gram alcohol per day for men and 20 to 30 gram of alcohol daily by women. Very interesting and important that alcoholic liver disease development does not depend on the type of alcohol drink, and WHO does some recommendation, and according to this recommendation, standard dose of alcohol is equal to 1 drink, and this 1 drink includes 1 can of beer, 1 glass of wine, and 1 shot of vodka. So sometimes it's very dangerous, not sometimes, it could be very dangerous for liver if somebody every day drink a little bit beer. We discuss about all morphological features. I just will show you microscopical pictures in different forms of alcoholic liver disease. So the first is steatosis. We discussed with you that predominantly it represents macrovesicular steatosis, sometimes with area of microvesicular steatosis. Hepatitis, again you see severe fatty degeneration of liver with hydropic changes, Mallory's body formation, and inflammatory infiltration. And finally, micronodular cirrhosis occurs. You can see false lobule in the center of slide, surrounded by thick fibrotic septa and fatty changes in the lobe without normal orientation of hepatocytes and without central vein. Other disease, very interesting disease, we name like non-alcoholic fatty liver, is a spectrum of conditions characterized by histological features similar to alcoholic liver disease and are manifested in individuals who do not consume alcohol in quantities that have a damaging effect on the liver. Non-alcoholic fatty liver disease include the same forms: steatosis, steatohepatitis, and cirrhosis. According to epidemiological data, we distinguish the most important epidemiological features associated with non-alcoholic fatty liver disease. First of all, gender. In female, this disease is most common. It's associated with obesity, with type 2 diabetes, hyperglycemia, impaired glucose tolerance, and hyperlipidemia. And very important to memorize that morphologically, non-alcoholic liver disease impossible to distinguish from the alcoholic liver disease. So if we have no information, clinical information about patients, so it's impossible to distinguish non-alcoholic and alcoholic liver disease. And in the end of lecture, we will briefly talk about obstructive diseases of the biliary tract. These diseases include secondary biliary cirrhosis, primary biliary cirrhosis, and primary sclerosing cholangitis. So, secondary biliary cirrhosis, the main causes are associated with obstruction of extrahepatic bile ducts like gallstones disease, stricture of bile ducts, cancer of the pancreatic head or major duodenal papilla, atresia of bile ducts in case of congenital malformation, and morphologically we will see pronounced chronic cholestasis, neutrophils around the bile ducts, swelling of the portal tracts, and finally cirrhosis and severe portal fibrosis. So here you can see morphological features. So false lobule, lacking the radial pattern of hepatocytes, absence of central vein. This false lobules is surrounded by fibrotic tissue, fibrotic or fibrous septa, and the bile ducts are filled with bile, and we name this phenomenon like bile thrombi. Primary biliary cirrhosis, other disease from this group, is a chronic, progressive, often lethal disease characterized by destruction of intrahepatic bile ducts, inflammatory infiltration of portal tracts, and fibrosis, with a possible outcome to cirrhosis and liver failure. Causes of this disease is autoimmune destruction of intrahepatic bile ducts, and very common in the patient we see association with other autoimmune disease. Primary biliary cirrhosis is most characteristic for female. Morphologically, we will see cholangitis, infiltration of portal tracts by lymphocytes with the destruction of the bile ducts, chronic cholestasis, and cirrhosis represents the final stage of the disease. So here in this slide you can see typical morphological features. So here there are bile duct, and here there are bile duct, and we see severe inflammatory infiltration, and this infiltration destroy the wall of bile duct. The same here, we see some bile ducts, but other one are destroyed by severe inflammatory infiltration. And the last disease from this group is primary sclerosing cholangitis. Is a chronic progressive disease characterized by inflammation, fibrosis, obliteration, and segmental dilatation of intra and extra hepatic bile ducts. The diagnosis could be made by retrograde cholecystopancreatography. We can see typical changes like in this picture, wall irregularities in the arrows. They are visible in undilated bile duct. So wavy surface, but in undilated bile duct. The gallbladder is typical enlarged. Again, the cause is related with autoimmune process, autoimmune destruction. In 70% of cases, this disease is associated with ulcerative colitis, and this disease is most typical for the man than for women. Morphologically, we will see periductal onion-like fibrosis of portal tracts with segmental stenosis and chronic cholestasis. Outcome is cirrhosis. And so in this slide you can see typical morphological manifestation of this disease. You see bile ducts and onion-like fibrosis. Thank you for your attention.